Thank you very much, Dr. Levine, for the kind words. Good evening, everyone. Thank you, Denbright, for giving me an opportunity. So we'll get started. Today, the topic of our presentation is digital full arch success, choosing your path, freehand, guided, with or without grammetry. So what I will try to do is start with the basics, which is always a disclaimer that I'm a full-time employee of my company. I'm not receiving any financial compensation for this lecture. This is my opinion. So, and there are some different kind of methods I will be using, the techniques. I'm just giving so this is a general disclaimer over there. And I'm not promoting any products or services here. So where I'm located, I'm in Green Bay, Wisconsin, and I'm right at the center of Green Bay, providing high-end service to my patients. This is where I'm located. This is my business card. If anybody wants to start the QR code, you can get the information. As you mentioned, Green Bay, Wisconsin, the first thing which comes to our mind is Green Bay Packers, so which is one of the only city-owned team in the franchise and have won more title, including the World Championship since it started. That's my office on the upper right. A little bit about, I was trained at, did my fellowship at Memorial Sloan Kettering Cancer Center in New York, trained at University of Connecticut, School of Dental Medicine, and University of Connecticut Health Center. So that's a little bit of Wisconsin. Summer, to the right, my family enjoying the snow as we speak. It's approximately around -8 degrees here. So learning objective, as they are there in the email and the brochure you've received, we'll try to cover all these topics and we'll do step by step so you guys can get an idea. A little fun fact before we start the main part of the presentation. Wisconsin is very famous for a lot of things besides cheese and Packers. A lot of hunting opportunities, hiking trails. The best of all is there is one of the few sandless. There's a beach on Washington Island, which is one of the few sandless beaches in the world. So that's where I am on the right side. You can see it's limestone. There are no sand, so it's just one of the wonders. So let's start with what I believe in. So the important factors are anytime you're designing and trying to deliver high-end care, you want to have a prosthetic design. And that prosthetic design comes from precision planning. If you can do it fully guided execution, that will lead to the best success for us. So we are trying to design and then go down where the bone is, and rather than going from the bone, going up. So we need to know where we want the outcome should be, and the foundation goes with it. So this is what my mind, anytime I think about it as a prosthodontist, I think about a flow chart. So when we are talking a full arch solution, there are two kinds of patient we can get. We are looking at a patient who has who's partially edentulous with a hopeless dentition, or somebody has already made him edentulous, so made a denture, or he's already without teeth. So from there, we need to figure out what are the possibilities. Either we can go fixed or we can go removable. If you go into removal, everybody knows about dentures, of course, or implant supported overdenture, which increases the success of dentures. When you talk about fixed, we can go into two tangents. I just classified this as a way, but there are different ways of doing it. Fixed detachable removal prosthesis, also known as hybrid or all on X. You can make it out of zirconia or resin with a titanium framework, full zirconia, whatever material you choose, or you can make a metal framework with individual telescopic crowns. Or you can talk about FP2 and FP1, where you can do metallic ceramic restoration. It depends how much of the pink you are replacing. It could be segmental, it could be full arch. So what are the options as we discussed in the last slide? This is more of a visual. Fixed implant AOX, all on X. People call it like whatever implants you're placing. It could be all on 4. Some people call, so it's just different terminologies. Second option is overdenture. It could be 2, it could be 4, and then a conventional denture. So let's switch gears and talk about, as we talked about, everybody is hearing about photogrammetry, photogrammetry. Photogrammetry is basically nothing, a new science in the world of engineering. It's basically a device which captures the 3D object and put it into in a format. What you see on the left side is an example called ICAM. On the right is PIC. And middle are basically their dominoes, which you try to capture. So you're located outside the mouth and you're trying to capture in the dental world implant positioning, which is critical because when you take teeth out, you place implants, you want precision, you need accuracy, you need the trueness. And what you want is undistorted so you can deliver very precisely fitting prosthesis. Photogrammetry for extraoral has been there for last 12 to 15 years. There are a few market leaders like ICAM or PEC. There are new players in the market like Micron Mapper, Grammy, Topo. They are there doing the job. Then comes intraoral scanning, which is everybody has an intraoral scanner in their office, or intraoral photogrammetry. The one on the left is basically a scan letter. I'm just giving example. I'm not advocating any or promoting anything. In the middle is basically a scanner, which is one of its kind, which uses both photogrammetry and intraoral scanners, so best of both worlds. And on the right is basically you can use your intraoral scanner using these metallic gauges, which can give you a precise details for us and in terms of capturing the impression. Or you can, some people like to use the regular scan bodies and try to do that. Everything has their own merits, pros and cons, and that's we have to be careful about. This chart is appears to be washed out on the screen, but this is, I got it from ICAM website, where of course they are trying to promote, they're trying to compare all extraoral with aoral elite. Shining 3D oral elite is the new kid on the block, launched last year after a lot of beta testing, which they combined two scanners into one. In the past, we were using intraoral scanning and then using extraoral photogrammetry, combining it. Of course, it's from ICAM website. They claim they're the best, and then others are, but this is just a comparison of people who are in the market. Of course, since they're in the field for last 12, 15 years, there are more studies about it. It's still considered as a great standard of care if you're trying to do that. And then when you compare, the results are amazing. Aoral Elite came last year, and it has basically changed the dimensions, how we do things and how we can deliver. Of course, there's a price tag attached to it. That's a photogrammetry unit could range from a high-end one, could be from 40 to 45,000. If you're looking at some baseline one, they could be somewhere between 10 to around 25,000. Aoral Elite is in between, and you're looking at some kind of like latest technology. In one, you need an intraoral scanner, an extraoral photogrammetry unit, or you can combine it with the smaller units. It's still an extraoral, and you can combine with the intraoral unit. Before I go into the cases, I just want to keep it a little bit of a boring part in the beginning. Of course, when we're talking about any presentations, we need to know what the current status. So I just put some articles there. I don't want to bore you. This is a clinical lecture, but I just want to. So first thing, it's a systematic reviews are considered high end in terms of they have. So this is a Medlines Google Scholar search by Hussein, and he talked about photogrammetry in general. And he looked it up since 2011 to 2021. This was published in 2023. So pretty much trying to cover extraoral photogrammetry, what it is all about. And after looking at the articles, they found 20 articles in this inclusion criteria. And the initial report suggests the photogrammetry could be a valid and a reliable clinical tool in dentistry, but more research is needed. There are a lot of articles, if you pull it up, and that will say the accuracy of extraoral grammetry is great. Then let's move on to a comparison. Of course, if you talk about photogrammetry, people will start asking, what about my scanner? Can I just use the scan bodies which I'm using for single implant? Yes, there are people who are advocating we can put different things in there. So they compared iOS like Treos, which is a high-end scanner, with ICAM. And here they found out that the intraoral scanning for fixed implant rehabilitation for a edentulous jaw versus the conventional scan bodies should be taken with caution because of the precision. Especially in mandible, it's tricky because we have limited tissue. Upper, we have palate. We can use that as a reference, but that could be a problem. So photogrammetry is superior to an intraoral scan, which 100% agree. And this is one of the latest study from Boston, and some reputable names are over there. And this is talking about the comparison. Another one, if you look at it, in this one, they're trying to compare intraoral photogrammetry, which is IPG, with digital impressions, but this is an in vitro study. In this, what they try to compare aoral elite, which I showed you, a grammetry with intraoral scanners, and they want to see what the advantages. They found that IPG could be more accurate and it's a reliable method. So they are basically creating, and with this study, this is more superior than conventional iOS. So this is the most probably the last one I'm going to bore you with, and that's about the clinical accuracy with photogrammetry, extraoral, intraoral, and snap-on markers. So in this, what they found out that the scanning technique between extraoral and elite showed the best results. So that means intraoral photogrammetry is very good alternative to extra. You don't have to have 2 units, you can use one. They compared Trios 5. I have Trios 5. I have a grammetry unit with Shining 3D, and I have used and seen extraoral photogrammetry as well. I have tried the scanner, so I'll show you some of the stuff in my presentation and we'll talk about that. I forgot about this one. This is one of the studies. This is actually not a paper. This is a thesis for Dr. Stanley. So I could not, I just put this over there. He worked with one of the partner, Denbright Labs, and they basically look at the guided surgery. Since I talked about guided surgery, how accurate is guided surgery? There's a lot of literature which supports that it's within, if you place an implant, it's approximately, always keep a margin of 1 millimeter. With this guide, they try to work on cases between 2020 and 2025 using co-diagnostic, which I use for my planning, and with the synergy workflow with one of the sister labs with navigation. And they found out that there was a 2 millimeter safety margin we should keep when we are using this guided flow. Because if your guide is off, everything is off, your bite, foundation, everything is off. So that's a good, that's a thesis. I cannot get more details about it, but that's a good study between that lab and most probably a student who was doing his master's. Okay, we'll quickly cover this, and so we can cover the cases. So this is basically what we hear: FP1, FP2, FP3 for fixed cases. FP1 is basically crown and bridge. You're not replacing gums, you're taking the teeth out. Precision of implant is very important. It goes into the right spot. If you're placing an implant in canine side, it has to be in canine side. You cannot place it between 6 and 7. FP2, you're trying to replace something, but you have to be replacing crown to root ratio pretty much the same, but a little bit of a pink we are trying to replace. FP3 is a conventional Brandemark style, taking same reduction, 15 millimeters. You're looking at the pink replacement or the gum replacement and the teeth replacement. Removal, 2 options. Since we are not covering, we'll proceed to the next slide. It's basically about overdenture or with the bar supported ones. My family, my kids, one of the best waters, if you want to see, my recommendation is always Turk and Caicos. If you have not been there, you should go and try. That's one of the most beautiful places in the world. So let's move on to the data acquisition. So step by step, the first thing is, if you sat down with a patient, now you have determined that person has a failing dentition or the patient presented to you without teeth. So what do you need to do? Of course, we need the data. The data comes from digital because we are trying to follow a digital workflow. That's me. First step is we need a cone beam CT to look at the 3-dimensional and look at a vital structure, look at the sinuses, look at the condition of the teeth, look at if there's any infection, what can we do to provide care to the patient. And the second step is, of course, we need an intraoral scan so we can merge the data together. I have a 3D face scanner, so I put myself over there. The beauty of this is basically this is a matte scanner I use. MediSmile scanner, which is from Shining as well. It gives me the luxury. I can put my face, my teeth, and the DICOM data together. So everything is merged, and then I import that into ExoCAD, and I can do it in the third-party software. If you're using 3Shapes, Demo Wings, whatever you're using, you can import this data. And that gives me my facial planes. If you don't have that, take a two-dimensional photo in Byte with Smile and retracted Smile with the cheek retracted. So that's what you need. So that's the basic thing you need, and you share that data with your lab and start working. So if you look at All on X, the possibilities are you can put 4 implants, you can put 6 implants. You're trying to avoid ideally the sinuses, that's All on X. Or if you have room to do it at the back, you can go behind the foramens, or in the sinus. It depends on what kind of prosthesis you are trying to make, and where you want to place the implants, and how pneumatized the sinus, or how much as alveolar bone loss is present around the nerves. So what it is, in simple word, 4 to 6 implant placed between foramens and maxillary sinus. Final restoration, where typically a posterior cantilever. If you can place basically a distal implant, ideally I would prefer that in a molar region. Cost of this restoration is of course the highest. It's better than overdentures. Of course, this is the best we could do after as a third set of dentition for our patients. The satisfaction is the highest, and there are few post-operative visits. If you're using a digital workflow, you can cut down from a 6 to 11 appointment with the conventional analog impressions to maybe 5 appointments for the patient. So you make yourself more productive, more predictable, more accurate. Where do we place the implants? Some animations for that. Lower interforaminal, if you can get in, classic Brannemark approach. You can place all on four, sorry. And you can tilt the back implants to 30 degrees, put the midline ones either straight or angled. You can try to find distal support and molar region if you can put a short fat implant, because with implants, the most important thing is not the length, it's basically the size and the width of the implant. If it's wide enough, and you can place an 8 millimeter by 5.5, it's more surface area, and that's the concept which is very legit and which we need to follow. Placing a longer implant does not help you. If you have the room, you can do it, but the surface area is important, and this type of the implant and the surface of the implant is critical. So let's move on to our clinical cases, which everybody is waiting for. So freehand surgery in this scenario, then we will do a digital restoration with IO. So I'm trying to cover everything, but we'll start from IO because a lot of people are using that technique with intraoral scanner, either using the scan cap, scan markers, whatever they're using. So the patient presented to me, meet Bill. Bill is a pleasant person, and what he's looking for, sorry, my slide went fast a little bit, and he is basically looking to replace his missing teeth. He's referred to me from his general dentist, and the oral surgeon with the diagnosis of generalized severe periodontitis. And overall, he has a poor prognosis of his dentition. If you look at him, let's go inside and look inside his mouth. That's him. He has generalized periodontal disease. He's a chain smoker, a lot of red flags. Abscess dentation appears, a lot of patchwork, looking for replacement, unstable occlusion. So what are we looking at? Let's go a little bit, dive deeper into this now. You can see smile is compromised. There you go. So what are the findings? As we mentioned, there is a generalized severe periodontitis, right? Then we have defective restorations. We have unstable occlusion. We have aesthetic concerns. Person is a chain smoker. He has periodontal disease. So move with caution. If I look at the image, this is a two-dimensional image. Of course, I took a CT scan, but sinuses are more close, could not be ideal for terminal implants. We have to do a classic all-on-X technique. First step, what do? Have an intraoral scan, cone beam scan, photos, and a face scan. If you can do it, face scan is optional, but if you like it, most of the lab will not require a face scan. It's a good tool to have. It's just up to you what you want to do. Then let's go to the surgery now. This is the freehand surgery. I sat down with the surgeon. We decided to go ahead We know where the sites are marked with the teeth. Surgery went well. Implants are good. Notice a little bit of an issue on the upper left. It looks like the implant was stable, but it looks like it's in the sinus. So it was still torquing at 50 Newton centimeters because of the bone engaging the cortical plates. Decided to hold off on that. Did the conversion freehand in the mouth, smart conversion. That's patient the same day, both the arches loaded. So let the patient heal. In between the time, we went back in and we took that implant out. Oral surgeon replaced the implant for me, and we wait for the stability. 5 months later, patient came. He was working on his smoking habits. I just went over his periodontal disease and smoking. What are the risk factors? You need to educate your patients regarding all of this. And he was very responsive to this, and he worked on it. So of course, you can see everything. I talked the final abutments, checked the torque, everything was good. Then we decided to use IO and basically use fiducial scan markers over there using the protocol for Nexus. Then this is the prosthesis with next step is try-in. I'm basically, patient had a diastema before, and he in between came and asked me, can we duplicate the diastema? I said, sure, we can certainly do that. So we ended up replacing that diastema. This is a trying resin. We are trying to the fit and bite and everything. We wanted to see how he's moving. On the right side, I wanted to see the function. So he's moving his jaw, and I took some photos just to make sure we can communicate with the lab. After that comes basically the seating of the prosthesis. This is, I prefer the titanium framework with zirconia overlay on it. That's my go-to prosthesis. That's the prosthesis for upper and lower. Of course, there was a lot of periodontal bone loss, so there was hardly any trimming involved, but we have to just flatten the plane just to make things even. That's the final prosthesis in place. That's patient smiling. The patient before and after. The next one is guided surgery. In this case, we'll discuss digital final restoration using optics plane, which is another non-grammetry approach now. So we are not using any kind of photogrammetry. We are using our basic tools. We did intraoral scanning in the first one. Let's move on, change workflow, and do guided. So this one, meet patient Hannah. Hannah is a nice, wonderful lady, but she's frustrated with the dental care, been all over the place. She keeps on fixing her teeth, breaking them, losing more and more teeth. And then the oral surgeon said, you need to talk to her. She has a poor prognosis for the upper dentition, for the maxillary dentition. Lower dentition is not that great, but she would like to hold on to it. So she's seeing a dentist for long, and then patchwork is going on. Get one implant on the upper right. Let's do a crown. It's discovered by insurance. Let's do another implant, another crown, rather than giving a full-time solution. So that's like a piecemeal treatment which was happening. And if you look at it, if somebody present full arch option, she would have saved a lot of money. Now the thing is, she cannot afford the lowers for that reason. So we have to look at it. You see bone loss on the upper right implant, lower right implant has bone loss too. So she has caries, defective restorations. She's a chain smoker again. I don't get the easy one typically, that I get a referral from a general dentist. A lot of these are complex cases. So you can look at her smile, look into the finding, caries, we have peri-implantitis with the fractured crown, unstable occlusion, aesthetics is a concern. She's in customer service, so she's not liking that. Okay. So face scan taken, intraoral scan, cone beam. Next step, imported into diagnostics, which is a software from Straumann. We place Straumann implant in this one too. You can see the foundation guide, final prosthesis design. So basically, designed everything. I can print it, all printed on a sprint tray. So we have the foundation guide, fixation guide, and the bone reduction guide. and an implant guide. Ready for action. Place the first guide, make sure everything is stable and everything is secure. So you're using that as a reference. If there's anything in the way on the left, you see there's a hole over there. We have to take that tooth out because that was where the implant was. So first thing, we secure it and then remove the implant crown based on that. Next step, teeth out, foundation guide is already secure. Bone flattening or bone reduction done based on the bone reduction guide. Implant place. 5 Straumann BLX with SRA screw retain abutments, which is the equivalent of a multi-unit abutment for Straumann. Placed over there, torque. I typically prefer a 50 plus torque. That's what we achieve. In this, we use the guide as a reference. We put the optic splint, splinted in the mouth, scanned prior to the extractions, first after placement of the guide, then after the implant placement. So we have some fiducials. We can just align the meshes in the software, whatever system you're using. You're using 3 shapes, exocad, whatever you or your lab is using. Most of the Dentbrites uses both exocad and 3 shapes. So it's basically whatever system they're working, they will help you out over there. So then if their scan caps are placed, scan this, basically loaded the prosthesis right away. The lower implant was taken out, and then we replaced basically the left quadrant with the bridge and then right with an implant. This is an insert place printed in the lab on a print tray printer. Because I have a physical model, this gives me a luxury of having a physical model so I can use the inserts in this case. This is right away. Temporary prosthesis in place. This is the final prosthesis. This is the final outcome. I did a bridge on the lower left. She wants to bleach her teeth and maybe crown those teeth. We'll come back and do that. And then I did the implant on the right side. Next patient. So when we're looking at this, this is a case, a combination. We now move into a freehand surgery. Can we use freehand surgery and IPG? So in the first case, it was freehand surgery with intraoral scanning. Second, we did guiding with grammetry, which is basically not photogrammetry, but kind of like using a jig to do that. In this one, we introduce shining IPG with freehand surgery. Same thing. So first communication with your lab. New art is great, and basically what you need to do is look at Jamie. Jamie is interested in basically missing her lower teeth. She had an implant failure. Her lower dentation is not in a good condition. She has a diagnosis for caries, implant failure, and poor prognosis for the mandibular dentation. She's wearing a partial, not happy with it. Upper teeth needs some lot of work, but again, her focus is lower right now. So I typically present all the options, but it's just patients showing what they want to do. She wanted to get a fixed prosthesis on the bottom, and we will do some crown and bridge work on the top. So she's in a work in progress right now. What are we looking at? As I discussed, same protocol, findings, caries, implant failure, lower right implant at number 28 was removed 4 months ago, and the left implant is a narrow implant, which is not going to be a good candidate. So one was removed, the other needs to go. So if you look at clinically, she has failing implants, 2 of them, caries and defective restorations, unstable occlusion, which is a part of the problem. Those implants did not last because we are trying to put partials on those, which is not a good combination. We are missing teeth in the front. Ideally, I would not have placed those back implants. I would have gone with all on X to begin with. But again, that's fine. So implant needs to come out, and then we need to do. So what do we do next? Collect the data. IO scan, upper, lower, bite. CT scan, I reviewed, send the data to the lab. They sent me a file of a lower denture. And I have the file prior to the surgery. I basically will print, we call it a surgical template or a surgical denture, which I call it. I'm just going to print that. Sat down with the oral surgeon, talked about removing that implant, changing the implant which was there with a different brand. Talk about doing 4 implants. The purple one is an additional if we can find a stable bone. We were a little concerned about the buccal lingual width. I prefer, typically if I'm doing any kind of implant placement, 1.5 to 2 millimeters buccal or lingual. So agreed with the surgeon, let's do it freehand. We have some references. We basically print the denture. We can use that as a template, a simple old-fashioned guide. So here you can see what I have on the left top is an upper prosthesis, basically upper arch with the intraoral scan. I took the lower surgical template and basically picked up in the mouth where the vertical needs to be. Then I used the photogrammetry unit and scanning in the mouth for capturing my device and using a denture scan to get my basically alignment to align the meshes. And my occlusion is coming from my IO scan. So everything what you see on the left, that's basically what I calibrated, and it went on to the lab. And I am working with Frank, who runs the lab. Kenny is there. Jeff is in the implant department. They're very nice and they're very quick. Quick turnover, got the conversion, everything from the lab back, printed. I printed this and then seated next day because the surgery was in the afternoon. This is implant placement as we planned on the computer. Pretty much looks, there is no, it's not basically guided, it's freehand, so that's what it is. And then we are looking at printer, sprint tray again, printed it, and then I took the cantilever off. This is in mouth. This is in patient's mouth right now. This is in healing phase. We are working on basically doing some work on the top. So we'll work on that and get it done as the case is healing. Good turnaround time. Everything is done to perfection. Patient is in the healing phase. So let's look into now freehand surgery again. And this time we are using IPG-like, but we're using fiducials. This is good. The problem with the last case is aligning a denture to the soft tissue, especially in the lower arch, which some of the articles were saying, because when you do the surgery, blood is involved, so difficult scanning things. Number two, the flap is raised, so everything is moving. If you try to take a moving target and a camera, of course, it's going to be blurred. So it creates some problems. In order to fight that, you need some fiducials. So we can basically use our pre-op planning and use that as a reference. So this is what we're going to do here. So let's meet Lisa. Lisa has no upper teeth present. She has lost her teeth 10 years ago. She has a lower partial, which is not fitting, caries on remaining teeth, basically none. We need to basically remove the failing dentition with their only 2 teeth left. This is her 10 years ago. If somebody would have asked me, so I got this referred from a general dentist and says, can you just take care of this patient? Now she has lost all the teeth. So this is in 2015. I would have taken, what I see over there is disaster. I would have taken all the teeth out on the top and the bottom, and I would have done both arches all on X. She spent money on this. It's better to combine all this in one go. You take the teeth out, you take the implants, try to save you time. Surgery wise, you are healing well. One time, everything is done. Unfortunately, that was not the case. They took the upper teeth out, gave a denture. Patient didn't like the denture. Lower made a partial with crowns. So she spent a lot of money, which she could have routed towards doing a fix on both jaws. So patient came, and now there's a tricky issue here. We don't have teeth. So what do? Scan the patient, which is on the right? And then what are we going to do the next? We are basically going to make some record bases, print the record bases, or you can do it yourself. I typically use the VPS impression just to give a stable area. Then I put fiducial markers over there and scan the patient for cone beam. This is her mark, so I just need the vertical. Everything is there, as you know. This is this is basically the scan cast of what we need to do digitally on the bottom. As you can see here, we remove it 22 and 27. Nuart did that for me. And then the next step is to get the denture. I got the surgical template on the bottom. Upper, I will print it in denture resin base over there, and I will use Onyx stuff, teeth for the teeth part, and basically cure them together. So again, I'm ready for the surgery now. This is the IO photo from the intraoral scanner. We put these fiducial markers so we can basically track it back to our initial planning, so we don't have to worry about it. We know the vertical, everything is already planned before the surgery. Placed it over there, scan done. Second scan, implants are done, torqued. We put the grammetry in the mouth with the fiducial, scanned it. You can see the blood, how much could be a problem there. Perfect. After that, we put the scan cap for IPG for shining. Everything looks beautiful. This is the photogrammetry photo, which is basically showing calibration there. Protective cap, which are for Straumann place. This is the panoramic. Now, take a look at the upper jaw. Everything is gone. In 10 years, this person has no bone. She needs zygomatic implant or a IPS, KLS Martin type prosthesis on the top. So she's not a candidate, does not have the money to do zygomatics, so she will afford one arch. But if you look at it 10 years ago, all that extraction, crown and bridge, partial indenture, if you combine the cost, we would have done another arch on the top. Patient would have been much happier. So this is basically there. Send the case. Now on the lab end, what's happening? New art is taking the pre-op plan, merging everything together from the scan what I sent, the lower arch on the top with the surgical template. Basically, they're matching everything. This is the fiducials matched with the pre-op. You can see it here. The last thing, implants combined over there clinically. What we did, now in the lab side, they all prepped it together. Next thing, they designed the prosthesis, did a great job from New Art, putting things together. Here you go, upper and lower prosthesis. And then basically upper denture in place, lower prosthesis, loaded. I typically, sometimes if it takes a lot of printing, I'll just typically try to do it by the end of the day. Sometimes the surgery is longer, patient is tired, I try to do it the following day. So that's a good success, excellent turnaround time, excellent matching over there, aligning. So this case is guided implant surgery with restoration and using IPGs, okay? So this is the last case, meet Lisa. Lisa has a failing dentition due to cavities, and she is losing all her teeth. Look at the condition. I don't have to say much. In respect of time, I'll keep on moving. Upper and lower dentition, you can see there are a lot of temporaries done by the general dentist. He sent it to me and says things are failing. So we just need to talk about oral health, maintenance, and all that stuff. What do we do now? Everybody's an expert who's listening to me right now. And what do we do? IO scan, intraoral scan is done. Right side of CT scan is segmented from there. Phase scan, send it to the lab. I'm using one of the sister labs because I'm doing guided, and they offer a product. So it's one of the sister labs I was using for this pre-op scan. A lot of caries, a lot of failing dentition, retained root tips. This is the planning. From there, we also evaluated FP1 versus FP3, but because of the smile line, we decided to go with FP3 in both jaws, 5 implants on the top. So this is the carbon fiber guide, which is more stronger than the one I showed you in this case, number 2. If you look at it, basically here, we secure the base on the upper left here. Number 2, guide in place, teeth taken out, flatten the bone, place the next one, secure it with locks, implant place, SRA loaded. You can see beautiful reduction by the surgeon. This is under general anesthesia. Here we're trying to combine now. First case was optic spleen. This time we want to bring in IPG. How can we merge technology? So everything is planned ahead. We're using that as a reference. We're going to align meshes. We got a SIM device. We put the markers in there, scan it, the grammetry. That's what we are trying to do. Send it to the lab. This was pretty quick. Let's put it this way. I sent this. They were on hold. Typically, New Art will be on hold. This case was done with one of the sister labs, and 20 minutes later, I had the design, and I click on the print, and printer is running. It takes typically between 30 to 45 minutes to print, stain, and glaze, and basically characterize. Here's the patient, post-operative CT scan, 5 on the top. Typical all-on-X kind of an approach on the bottom. I wanted to avoid cantilevers. I was able to do that. 6 implants, all-on-X in the kind of, you can see all-on-4 style between foramens, but 2 distal implants to avoid cantilever. As a young person, I don't believe in doing, I can do all-on-X and save money. We want to do what's best for the patient. That's the philosophy I follow. I treat everybody as I want to make sure that I can do the best job for them, what I would prefer for myself. So there you go. This is the patient before and after, and you can see she's in a temporary prosthesis leg right now. This is 3 days later after the surgery, not 3 days, 2 weeks later after the surgery. So this was loaded the same day, but I took a photo because you'll be surprised what happened to all the swelling. My patients heal very well. So it's 2 weeks, and you can see patient is very happy. We are waiting for the healing. So dot on time, 7:45, as I was told, to get things going, so we have time for Q&A. That's the New Art team. Thank you, Dentbrite, for sponsoring this event and basically giving me an opportunity. New Art is an amazing lab. I work with all of them. You can see Frank, Jeff, Connie, AJ is over there. That's the implant team. And so that's for that. And then before we do that, of course, a trip to Greece and the Holy Land, you can see on the right. So now let's talk about the last part. Everybody's waiting for the what's my take-home message. So my take-home message for this is immediate implant placement and loading of implant is very predictable solution. It's been going on for last more than 20 years, and it's something I would recommend. The important thing is identification of identification of patient needing full mouth implant treatment is very critical. You have to decide which case is a good case, which is not a good case. We need to identify risk and benefit. Are they medically optimized? What are the risk factors? How we are going to deal the patient education. It is possible to place and restore full arch implant in dentally complex and compromised patient, which I do in routine, and it's basically documented all over literature, and it's a very predictable solution. The next one is utilizing guided surgery and photogrammetry, in my humble opinion, is the best recommendation. If you cannot do it, you can do basically freehand surgery. Ideally, it is better to be conservative in medically compromised patients with bisphosphonate use, radiation, delayed loading is recommended. If the implants have good primary stability, it is recommended to load. All-on-X is, of course, a stressful, risky approach because you have to deal with a lot of things. You have to be ready. Patient needs to be educated, what to expect, diet, surgery, pain, swelling, maybe temporary paresthesia, a lot of things, failure, complications, smoking, bisphosphonates. We need to discuss all of it. The most critical part, in my opinion, is a good team you have. If you're doing the surgery yourself, it's great. If you're working with oral surgeon, periodontist, or a prosthodontist, or you're doing it all yourself, the most important thing, you need to have a lab which can deliver this. Like, I'm lucky to have New Art here, which can help me out. Great team leads to great predictable solution. If something you are sending them, they can align properly, send you back, less complication. That's what it is all about. So I'm going to sum up my presentation right over here. So I just want to thank you for giving me an opportunity to speak. It's 7:48. One last thing before Dr. Levine take over for Q&A is they are doing this promo code for attending this session. They're giving you a 10% off on zirconia hybrid prosthesis. So please do utilize that. If you're looking into this question, if you have any questions, feel free to reach out to me. My information was there in the presentation. So thank you very much again, Dr. Levine. Back to you.